Welcome to AJP Audio for May 2023. I'm Aaron Van Dorn. Ms. Arad, a researcher at the School of Psychological Sciences at Tel Aviv University in Tel Aviv, Israel, joins us to discuss a non-pharmacological intervention for the treatment of social anxiety disorder in comparison to standard care. Afterwards, we'll once again be joined by the journal Editor-in-Chief Dr. Ned Kalin to discuss the rest of the May issue. Ms. Arad, social anxiety disorder affects between 4 to 12% of the population and shows only moderate response to current frontline treatments, selective serotonin reuptake inhibitors, and cognitive behavioral therapy, with around half of patients prescribed these treatments continuing to show symptoms. Your study looked at a new non-pharmacological treatment called gaze-contingent music reward therapy. What does that consist of?
Gaze-contingent music reward therapy, or GCMRT for short, is based on findings that compared to non-anxious people with social anxiety tend to turn more attention to and to dwell longer on socially threatening stimuli. These can be negative or uninterested facial expressions in an audience while speaking publicly, or even a hint of disapproving expression in a social gathering. This attentional tendency is implicated in the maintenance of social anxiety, and therefore is the target of GCMRT. We used eye tracking technology to reduce this tendency, applying musical feedback. And in each session of GCMRT, patients first select music that they enjoy listening to, and then they're instructed to gaze freely, as they like, at matrices of faces with either disgusted or neutral expressions, while their gaze is continuously tracked. And as long as they're looking at neutral facial expressions, the music they chose keeps playing. But whenever their gaze turns to the threat-related faces, the music stops. This feedback is meant to adjust gaze patterns to be more like those of non-anxious individuals, and eventually to reduce symptoms. And previous clinical trials have shown that this type of treatment is quite effective when compared to tight controls in the past.
Your study split patients between three arms: GCMRT, which you just described, SSRIs, and an active waiting list control. What were your results?
Most importantly, we found that both GCMRT and SSRI were both more effective than waitlist control in reducing social anxiety symptoms, and that no significant differences were noted in the efficacy of these two active treatments. This result was found both when symptoms were assessed using a clinical interview and when patients self-reported on symptoms. What we also found was that GCMRT was acceptable and made as much sense to patients as the pharmacological option. And this suggests that GCMRT, which is a relatively new and low-cost and accessible treatment, is comparable to SSRI, which is a well-founded and effective treatment for social anxiety. And I'll add that, importantly, when it came to depressive symptoms, which are highly comorbid with social anxiety, we found that SSRI was significantly more effective than waitlist control, whereas GCMRT didn't show such an effect. So although no significant differences were noted between GCMRT and SSRI in reducing depressive symptoms, it does seem that for social anxiety with comorbid depression, SSRIs may be more effective, which is not surprising because it replicates findings from separate previous trials in SSRI and GCMRT separately.
Patients in the GCMRT arm showed significant reductions in the dwell time on threat faces. What does this result suggest?
Essentially indicated effective target engagement with our treatment protocol. What it means is that we were able to alter gaze patterns using the musical feedback that we provided. What strengthens this finding is that this reduction in dwell time on threat was observed only in the GCMRT group and not in the SSRI or waitlist controls, which implies that this is indeed the result of the applied feedback in the treatment sessions.
What were the limitations of your study?
There are 4 limitations to consider. So first, we used waitlist as our control group, and this could be considered a weak control. It doesn't account for potential placebo effects. However, response rates in this study were high and comparable to previous published trials, which indicates that clinical improvement was most likely not fully due to non-specific treatment effects. Second, although no significant differences were found between the GCMRT and SSRI groups in social anxiety symptoms, the current study wasn't a non-inferiority trial, so such differences can't be ruled out entirely. Third, long-term effects weren't measured, so the last measurement was taken 1 week post-treatment. Future studies could assess longer-term effects of both treatments, especially as SSRIs are commonly recommended for at least a year, while GCMRT is a short, acute treatment plan. And lastly, a limitation of this study is that for both treatments, clinical effects were limited, with average LSAS scores remaining in the clinical range post-treatment. And while this is consistent with the results of previous trials in social anxiety, it does imply that there is still more work ahead of us in improving treatment efficacy.
Are there any immediate clinical implications for your findings?
Given that up to 50% of patients with social anxiety remain symptomatic following a full course of treatment, and that relapse rates are quite high, having new effective treatment options for the disorder is important. And this study indicates that GCMRT, which is a short and low-cost and minimally demanding treatment option, is a viable alternative for treating social anxiety disorder. As eye tracking technology is becoming more and more affordable and accessible, this is pretty exciting news for the field.
What's next for your research?
We're continuing to explore the clinical effects and underlying mechanisms of GCMRT with the hope that such knowledge could be used to enhance treatment efficacy. For example, we're working on a study exploring the possibility that GCMRT may affect basic attentional control capacities in addition to specific threat-related attention patterns. And in addition, in this present study, we actually collected pre- and post-treatment MRI data that shed light on common and specific neural processes underlying GCMRT and SSRI treatment.
Ms. Arad, thank you for taking the time to speak with us today.
Thank you. Thanks a lot.
Up next, Dr. Ned Kalin. Hi, Dr. Kalin, and welcome once again to AJP Audio.
Thank you. It's a pleasure to be with you.
The May issue of AJP focuses on treatment issues. Earlier, I spoke with Ms. Arad about the use of a digital intervention in the treatment of social anxiety disorder. What can you tell us about it and how it fits into the May issue?
Well, this issue is devoted to either presenting new treatments or thinking about how we can enhance current treatments for various psychiatric disorders. And this particular paper, as you mentioned, is focused on social anxiety disorder and uses a really interesting intervention, which is basically attempting to modify one's bias towards threatening stimuli, or in this particular case for social anxiety patients, towards threatening faces. And so the intervention that is being explored here is training individuals to not attend preferentially to threatening faces, which is a particularly relevant stimulus for people that have social anxiety disorder. So in this study, there were three groups. One group got this training that was eye tracking based attention bias modification, 10 sessions over a 12-week period. Another group got standard SSRI treatment with S-citalopram up to 20 milligrams. Turns out that the average maximum dose over this period of time was only 11 to 12 milligrams, which is important to keep in mind. And then finally, there was a third comparison group that was a waitlist comparison group that were told that they would later get the attention bias modification training. And the findings were interesting. The findings basically showed that the attention training, bias training, was as effective as the SSRIs. So it was sort of a non-inferiority trial, but both treatments, active treatments, were significantly better than the waitlist, which you would expect. It turned out that the SSRI treatment group did better from the standpoint of if they had comorbid depression symptoms, they tended to get better, whereas this was not the case in the eye tracking based attention modification group. Interesting finding, a new approach to treating social anxiety, one that does not use pharmacotherapy. One thing to keep in mind in this study is that the average dose of S-citalopram was only 11.6 milligrams per day. We tend to think of therapeutic doses more in the 20 milligram range. And so one of the issues in interpretation would be to keep in mind that this arm of the study had a lower dose of medication than you might want to use clinically.
Next up, we have a study looking at the treatment of trichotillomania and skin picking disorder from Brandt and colleagues.
So again, another interesting study examining a new treatment. In this particular case, the study was focused on using the NMDA antagonist memantine, which is used for the treatment of memory impairment and Alzheimer's disease. Memantine is interesting because one of the mechanisms that's hypothesized to be associated with these habit-related types of pathophysiologies is alterations in the glutamatergic system. So in this particular study, the investigators had 100 participants. They were randomized to receive either memantine 10 milligrams a day for 1 week and then increased to 20 milligrams per day, or placebo over an 8-week period. Important to keep in mind that the patients included in the study either had trichotillomania or had skin picking disorder. And so they were clumped together. And some might argue that the groups should be separate, but I think there's a good rationale for putting them together. Both are these pathophysiological alterations associated with habitual self-directed behaviors. The primary outcome measure was a change in the NIMH symptom scale that was focused on trichotillomania. And basically what they found was a fairly strong effect of the active treatment memantine. 60% was a 60% reduction in the clinical global index improvement scale in the memantine group as compared to an 8.3% improvement in the placebo group. The scale that was specifically used for trichotillomania that was developed also showed significant reductions in the treatment group. So a fairly strong effect with a new treatment, holding interesting promise for folks that suffer from these difficult to treat disorders.
Reddy and colleagues look at a novel treatment for schizophrenia that combines two different treatments. What did they find?
So this was a study that is particularly focused on negative symptoms of schizophrenia, and more specifically, even the motivational components of the negative symptoms. It's believed that the negative symptoms and the motivational components, that is reduced motivation or a decreased drive, are really very much linked to the functional disabilities that patients suffering with schizophrenia have. And so this is a psychotherapy-based intervention in individuals that received either 12 weeks of the intervention, which was a combination of both motivational interviewing and cognitive behavioral therapy. The individuals were also followed for another 12 weeks. So the study sort of lasted for a total of 24 weeks. And the focus, again, and the primary outcomes were symptoms related to decreased motivation, decreased pleasure, and that core of symptoms that gets at some of the negative symptoms of schizophrenia. The combination of motivational interviewing and CBT is rather unique. And the idea here was that the motivational interviewing, along with the CBT, would not only target the symptoms that are associated with amotivation, but also would enhance the likelihood of adherence by increasing the motivation of the patients. And what the investigators found was, in fact, that the combination of motivational interviewing and CBT had a more prominent effect than mindfulness treatment alone on these measures, and that this was obvious at 12 weeks when the effect was most prominent. The downside of this is that when the investigators looked out to an additional 12 weeks, the differences between the two treatments were less prominent. So it doesn't look like it's particularly a long-lasting effect. And also another concern was that when the investigators looked at functioning in the community, there was really not an increase in functioning after these treatments. So while there was a change in the symptoms based on the rating scales, this really did not translate to major changes in functional capacity for these patients. Now, despite that, it's a really interesting approach and holds promise, and probably is a important step to build on in thinking about how to further enhance this combination treatment and hopefully have this translated to better functional outcomes.
Continuing with the focus on schizophrenia, Taipal and colleagues looked at a burden of polypharmacy versus monotherapy in a cohort of patients with schizophrenia.
This is a really interesting study. It's performed in a large sample, over 61,000 individuals from Finland. These are all the individuals, at least supposed to be all the individuals that were hospitalized for schizophrenia between 1972 and 2014, so a very, very large cohort. And the analysis followed individuals or their data over a period of roughly 8 to 9 years. And the question that was asked was, when you look at these individuals, when they were on one medicine, one antipsychotic medicine, versus more than one antipsychotic medicine, versus not being on any medication, how did they do from the standpoint of significant medical complications or medical issues? And the outcome measure that was used there was hospitalizations that were non-psychiatric, and they could be medical hospitalizations or they could be for cardiovascular related problems. And somewhat contrary to what we might expect, in this particular case, individuals that were taking more than one drug or that had polypharmacy in a sense with the antipsychotics actually did better from the standpoint of non-psychiatric hospitalizations. This is particularly apparent at the higher doses of medications when they were used. One thing to keep in mind here is that this was a within subjects analysis. So this was looking at subjects over time and asking the question about when a subject was taking one medication, one antipsychotic versus more versus none, what was the likelihood during that period of having a non-psychiatric hospitalization. So somewhat contrary to what you might expect, polypharmacy is not always bad, and in particular in relation to schizophrenia patients, it looks like polypharmacy results in less non-psychiatric hospitalizations. There are a variety of reasons why this might be the case, and we have a really nice editorial by Dr. Robert Buchanan and Dr. Julie Crable from the University of Maryland that discuss this issue in general and also think about some of the other factors that might be related to the decreased medical morbidity that was observed in these patients.
And finally, Brandt and colleagues looked at the risk of experiencing overdose in patients undergoing treatment for opioid use disorder.
We all are aware of how critical the issue related to opiate abuse is and the overdose deaths, the cost to society and individuals suffering and families and all that. One statistic that really is striking is that from 2020 to 2021, CDC estimated that there were over 100,000 drug-related overdose deaths in the United States, and of these, roughly 75,000 were attributed to opioid overdoses. And so what this study did was, interestingly, looked at the likelihood of overdosing during treatment, medication treatment for opioid use disorder. And we all know that, and it's intuitive, that by getting treatment, you're reducing risk for overdose, but nonetheless, even during treatment, there are a significant number of people that engage in self-harm and overdosing activities. And so again, the focus here was to ask, during this period of treatment, what is the likelihood of overdosing and what are some of the factors associated with this? So this was a large data set that was acquired from 3 different randomized clinical trials that were performed with the National Institute of Drug Abuse Clinical Trials Network. So the number of individuals in the study was over 2,000 undergoing medication treatment for opioid use disorder or opioid dependence. And the 3 treatments were either methadone, extended release injected naltrexone, or a buprenorphine naloxone combination. They assessed the risk of overdose over 24 weeks after the beginning of treatment. And what they found was that over this time period, out of the roughly 2,100 individuals that were studied, 39 of the participants had at least one overdose, and there was a total of 57 overdosing episodes among those within those 39 people. And of those overdoses, 28 were due to opioids. Now, they asked the question, were any of the treatments associated with more overdoses, significantly more overdoses than the other treatments? And it turns out, interestingly enough, that those individuals with the highest level of overdose were in the naltrexone group. And in that group, 5.3% of individuals engaged in an overdose compared to 1.5 and 1.15 in the methadone and buprenorphine groups, respectively. And the authors speculate about why this is the case. And it turns out that the naltrexone group had more individuals that actually did not even initiate the treatment. Even though they were in treatment, they did not comply with it and did not initiate it. So that was one risk factor, which is obvious and was associated more with the naltrexone group. The other thing that was interesting is that when they looked at benzodiazepine use, they found that those individuals that reported taking benzodiazepines during the 28-day period prior to the study had roughly a 3-fold likelihood of overdosing as those compared to those that were not taking benzodiazepines. Now, why this is the case is not entirely clear. So overall, 2 risk factors. One is not really beginning or engaging in treatment, sticking with it. And the other is if one was taking benzodiazepines prior to the opioid use disorder treatment that was performed. Here, I think the take-home message is that even though individuals are undergoing treatment, they may not necessarily be complying with it or even initiating it. And those individuals may be at greater risk for overdosing during this period of time. And also, I think being mindful of the use of benzodiazepines in this population, especially prior to treatment, also looks like it may increase and enhance risk for overdose during treatment.
Dr. Kalin, thank you once again for speaking with us.
You're very welcome. Take care.
That's all for this month's AJP Audio, but you can check out other podcasts from the APA. In the April episode of Psychiatric Services From Pages to Practice, Dr. Dixon and Dr. Berzin are joined by researchers to discuss the effect of integrating patient-generated digital data into mental health therapy. That and more can be found at psychiatryonline.org/podcasts or wherever you find podcasts. The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.